never agreed to do weekend talks ever. I was chief resident at Hopkins, so I felt some sort of devotion to do that. And I live in Bethesda, so I could still go to my son's basketball game. We won, actually. Anyway, thank you for staying. I'll try to make it fast and actually packed with stuff. I'm going to move around only because I have a Fitbit on. And so I need my steps, largely because my dog also has a fitness tracker. And my wife compares our numbers at the end of the day to figure out who's going to bed. So anyway, I'm going to walk around. So again, I'm Carey, Greenspun. I'm a physician, cardiac anesthesiologist by training. I've done some weird stuff. I was the chief medical officer for Dell before I joined Deloitte. On the World Economic Forum's Global Agenda Council on Mental Health, the HIMSS board. So I've been around health IT for a long time. I actually got involved in it when I was back at Hopkins doing early, minimally invasive heart surgery. And we're tracking those patients with paper forms like everything else. There's this thing called the internet. It's kind of cool, and maybe we can track them that way. So that sort of launched me into a career. I did need to say something profound because it's the last talk of the day. You guys are drinking out. So you got to put that together, right? Deb's comments were really interesting. Sort of talking about the brave new world. I want to talk about how we're getting to that world and what's changing, why that's so significant. And the big change that we're facing right now is this transition from fee-for-service into value-based care or outcomes-based care. And so first person into medical. One of the things that makes it so important is that what it opens the door for is a tremendous amount of innovation. It changes how we give care. And it also makes us do stuff that we're really not very good at. It makes us share information, it makes us coordinate care, it makes us engage consumers in a way that we haven't done before, and it makes us use data. It allows us to do a lot of really cool stuff that either has been around for a while or is brand new. It's interesting, so Deb mentioned telemedicine. How long do you think telemedicine's been around? Anybody?
20 years.
You got 20 years, anybody else? It's been around for over 100 years. Right? When the telephone was invented, someone goes, wow, awesome way to deliver healthcare, let's do that. Right? And it hasn't caught on, not for a lack of good technology. It's really for a lack of aligned incentives. So if doctors weren't paid to talk to a patient through a magical device, they wouldn't do it. There was a disincentive. They actually would be sort of losing money by spending their time doing that versus something else. And it's only now that you see, as value-based care, that we've got to save money. We actually, in terms of better opportunities, we have to make things more convenient for our patients. And so that telemedicine makes sense. Now, places that have done that, right, where it made sense, like you look at Kaiser Permanente, Integrated Delivery Network, the VA, they've done telemedicine for a long time. It makes sense. But other stuff, like, for example, secure messaging with your doctor. Right? How many of you can actually send an email to your doctor? A couple of folks here. And so what's interesting, when Kaiser started doing that, they were able to drop their in-person visits by about 20%. And when you're Kaiser, that's awesome. When you're Hopkins, that's a disaster. Right? Your volume drops by 20%, someone's losing their job. Okay? But it's only when you move into value you start doing it. So I want to talk about very quickly sort of 4 areas that I think are really important to change some of the business of medicine and realign it. First one is the sharing information. So we actually, in healthcare, literally bad sharing information. Why do we not share information in healthcare? What's that? What about the market? Yeah, it's bad business, right? So the reason people stick with their doctor knows a lot about them, and the way the doctor keeps them is by keeping that information. And so they won't go somewhere else and easily have some other doctor. That's the way fee-for-service works. Awesome. Right? But in a value-based world, if you, what's your name? Aisha. So Aisha shows up so if you're my patient, but you wind up like twisting your ankle in those shoes, right? You're going to go to another doctor. I want to make sure the doctor knows everything about you so you get the proper kind of care because I'm not going to pay for it. So I want to make sure it's efficient and they don't repeat a lot of stuff and everything is good. Right? So sharing information becomes a very important part of that. But sharing information sounds awesome, yes? Right? Anyone worried about having your information shared? But you're worried about security and privacy, so it's interesting. So privacy and security in healthcare is very different from other industries. How many of you worried about someone stealing your identity and draining your bank? Who's worried about someone stealing your identity and getting a colonoscopy? Right? Different kind of thing. What people are worried about in healthcare is not wholesale loss of your information. What's your name? Mike. So, Mike, you're not worried about that. You're worried about someone getting that little piece of information in your medical record that you don't want to share. That rash you got in Vegas or something. These are the kind of things that people worry about. It's not the whole, people are actually very willing to share a tremendous amount of their medical record, right? Because it'll help science, it'll help community, it'll help them a little bit, except that one thing. Right? So again, the vast majority of Americans have something in their medical record. Privacy and security is critically important, particularly as we get to an environment where, between not only your privacy within healthcare, but your privacy across the rest of what you do is becoming very sketchy. Well, what's interesting about consumers is that they will give up privacy for very little, as long as they get some benefit. Who's got progressive auto insurance? Anybody? Right, you back there. Do you have a little thing in your car? No. Okay. Oh, so you're like, are you a good driver? No, you're not. That's what they think, because you never made a claim. But you've been running over people left and right and paying them off in cash, right? Now we're having an honest exchange here. So what they did is say, look, you say you're a good driver, prove it. We'll stick this in your car. And when it does, measure how hard you accelerate, how hard you brake, what time of day do you drive, right? You're driving at 4 o'clock in the morning, back and forth, they think you're pretty bad risk, right? And it's a huge invasion of privacy. But what's your name? Adam, right? But for 20 bucks, you'll do it. Right? So we see a lot of this. Is that there's the consumer saying, like, you know what, I will give up some privacy so I can get something for it. The flip side, I think we'll also see consumers demanding, saying that I'm diabetic, I'm diabetic, and I check my blood sugars religiously, and I keep under control. I want something. I'm going to send, I want a place that will take my data, right? I'm going to share all this stuff. I'm going to give them my supermarket, show them that I'm buying kale instead of French fries, whatever it is. And I want something. So I think we'll see consumers demanding. Consumers are a big factor. Second thing I want to touch very briefly on is care coordination. Right now, who's responsible for making sure that all the right thing happens to a patient at the right setting at the right time? Who does that? No one. Including the patient. Versus there was when I was doing my oncology rotation, mine was like, Mr. Jones, you have cancer. If you don't have a daughter, you should get one. Someone's got to keep track of all this stuff. And the reason was that we didn't do it before because we didn't have to, right? Doctors got paid, hospitals got paid, doing a good job for people at the moment they were in the hospital and getting them out in a reasonably efficient amount of time. And that was it. No one cared what happened after. No one really, no one's financially responsible. No one said, like, I'm going to get paid based upon how well you do 30, 60, 90, 365 days later. Suddenly, if that's what you're on the hook for, you're worried about readmissions and other things, you start to worry about, hey, where'd they go? Who's taking care of it? Because bad things happen in these transitions of care. People think things get missed, things get repeated, people die, bad stuff. So how do we actually pull those together? How do we look at what's going on? It's driving a lot of consolidation in the industry. Because all of a sudden the system says, look, I got to have home health people I can trust. I have to have a rehab hospital I can trust. I have to have the data flow. The right things are going on. And therefore, again, this care companies can be a struggle that we have is to talk about electronic health records. Most of our EHRs are designed to document what happened between a provider and a patient, not to provide workflow across a lot of different settings. A team of people, often inside and outside different networks. We don't have that. So care coordination is going to be very important. I want to talk more about consumers and consumer engagement. This is the weird part. That in healthcare, I say consumers rather than patients, because again, people are patients only in front of providers. We need to figure out how to better engage consumers. Because now in a value-based world, that matters. When I was an intern at Mercy Hospital, I would see patients in the outpatient. And we tell them, like, you got to do this, 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 this. And then a month later, they come back and nothing has changed. I throw my hands up, like, oh, well, you can't change people, right? I guess what's even an anesthesiologist. But in a value-based world, we suddenly worry about that. We sort of think about how do we actually engage people. to help them make better choices in order to support the kind of health outcomes that they need. And other industries have done that. Who's a runner here? What do you got?
Say it again?
What do you have? You got to have something cool.
I have nothing. I have my I have my Nike ID.
You have Nike, so do you have a chip
Nike
in
Plus.
your foot, right? You have a computer. I got nothing. I got a computer chip in my foot that tracks your running. That's also attached. You have the Nike Run app, which is it's GPS enabled
Through my phone, yep.
right? You have satellites from space monitoring your exercise, right? Do you like exercising?
I do like exercising.
No, you don't. Right? You post your stuff on the leaderboards, right, against your friends.
Of course.
Right? Of course you do. You like the moral superiority of running your friends, right?
Yes. Yeah.
Yes, exactly. So other industries have figured out how to get us to do stuff that we don't want to do. Nike's a fascinating example. What Nike found, first of all, was that if you make data collection automatic, people are much more likely to do it. How many of you had like a regular pedometer, old school pedometer? How long do you wear that thing?
5 minutes before I get the
That was it. So, but the average person keeps it for 2 weeks. Right? The magic number is what it's off. But you, with this Nike thing, Nike found if you make it automatic, it's going right to your phone, you don't have to do anything. Right? You're actually much more likely. What's more important is they found if you make it social, you have a leaderboard, you're competing with people, you're 10 times more likely to reach your goal. You look like a very fit guy. So I'm assuming this is all because you're competing with your friends. Same thing like me and my dog, right? We got a thing going. So other industries have been able to figure out how to change behavior in a way that healthcare hasn't really done. I mean, I fly on the same airlines, I stay in the same hotels, I go to the same grocery store, and because I go to that grocery store, I go to a particular gas station. They've all worked this kind of stuff out. No one's forcing me. But there's a weird thing in healthcare, too, among us. It's about quality. So who's got a good diet? Not a trick question. Nobody. How do you know?
I've had since I was like 10, my whole family goes to them. All our close.
He knows everything about you. You've seen him for a long time. Seems like a decent person. Awesome guy. How do you know?
I search online.
You search online. What did you search on? What did you search?
There's like physician comparison together.
And you saw other patients.
Right.
Okay.
And then also work.
Okay. So what's interesting, what both of you described in a fascinating way, is the experience of going to Dr. talks to me, Dr. available for me, Dr. knows me, they're efficient. No one says that based upon my age and my family history, I have all the necessary preventative care that I'm supposed to get. No one says that I had the same operation. What's your name?
Matthew.
Matthew. No one said that I had the same operation Matthew, and I was back to running 3 months before he was, or 3 months before. No one says that. They describe the service experience. If any of you have ever driven across the Delaware Memorial Bridge, you've seen the 2 billboards, one from one health system that says, our doctors are great. Hopkins says that all the time. And then the other billboard says, from different institutions, the current wait in our emergency room is 7 minutes. Right? Where are you going to go? Leave. 7 minutes. Right? And so it's about service experience. And your point issue was that you got these reviews. Is that most of the reviews available for people are from social media, which is really actually a reflection of service experience, not quality. All of us know people who continue to go to a terrible doctor despite awful outcomes because they like that. And it's not to the office staff that pisses them off. They decide they want to go somewhere. So it's a very, very difficult thing to deal with. But we also, when I talk about quality, right, and value is not quality or outcomes over cost. It's outcomes and safety. And service over cost, because consumers will act like consumers and make different choices. So we have my son had a work on his foot. I could have brought him back here to a world's famous cardiologist, or I could have taken him to theworkguy.com in Bethesda. Where did I go? Of course, the work guy, right? And we showed up there. He had a 4:30 appointment at 4:25. He's back in the exam room at 4:40. We're out the door with most of his foot intact, and I was delighted. If he had a brain tumor, I might have come up here, made a few more calls, whatever. But for me, service was actually much more important. I had a general expectation of quality. And so one of the struggles we have is sort of getting information about how do you get people to make good choices about quality, not just based on service. Now, you can give people information. That actually doesn't work very well. I'll give the classic example. Do you know what New York State has compared to any other state relative to cardiac surgery and cardiology? They have a registry of morbidity and mortality, mortality statistics for every cardiac surgeon and every invasive cardiologist. Any Dr. Oz fans left in the world? If you were, you could look him up and you could see his risk-adjusted mortality. For this one, understand risk adjustment, it says, I'm a cardiac surgeon, and if I take care of really sick people, I would expect 4% of my patients to die. Versus if I'm a cardiac surgeon who is very healthy patient, I would only expect 2% of my patients to die. So if I have 3% of my patients die, you need to know that's either awesome or terrible. Okay? Risk adjustment. So you look at risk adjusted mortality. So Bill Clinton, 2004, gets heart surgery. Where does he go? Anybody know? Not Cleveland Clinic. New York. Of course, New York, right? Because it's the center, right? So where in New York did he go? Columbia Presbyterian. What's your name? Oasis. So what do you think at that time, publicly available data said that the risk-adjusted mortality at Columbia was when he had his heart surgery? Better or worse than that? Better, of course, right? Anybody else? Worse? What's your name?
Preston.
Preston. A lot worse, a little worse?
I'll say a little worse.
A little worse? What's a little worse? Like percentage worse?
Percentage worse, I'll say
2%. 2% worse. Just so you know, when he had his heart surgery, the risk-adjusted mortality at Columbia was twice as high as the average. It was actually 11 times higher than the best performer in the world. Now, Hillary may have known that at the time. But bringing that surgeries back in the hospital complication, it's interesting that nobody uses that data. Consumers don't use that. It's just having it available. No one goes, but they still do all their same stuff. And payers don't use that data either. It's only the doctors go, wow, our program really sucks. We got to get that. And you sort of see this regression toward the mean. Right now, the data shows, for example, like if you have a heart attack, don't have it in all the just to say. Just giving people information is not good. There has to be some kind of incentive. Consumers need some kind of incentive. So, then we have the shore on top of that. I'll touch on one last thing, which relates to data. In the sense that we have done a very poor job with data. If you look at how people do stuff, it's rarely relevant data. Actually, before I get to that, I do want to add one thing about information. How many of you think that Hopkins is awesome because we're always like number 1 or number 2 in the U.S. news? They're called awesome. Like we are awesome, right? So what's interesting is how many top 100 hospitals are there in the United States?
100.
150,000.
So we have 100, 150. It's actually about 725. There are 725 top 100 hospitals in the United States. And what's interesting is that the big ones that do this, so you've got U.S. News and World Report, you have Consumer Reports, you have Leapfrog, you have Health Grade, some of the really big ones. How often do you think that that someone who's on top of one of these lists is available, that people will go, ooh, that's great. How often is a hospital on more than one list? 10% of the time. Only 10% of hospitals are on one list or on another. What's worse is that very often hospitals are on the top of one list or on the naughty list, right, of another list, right? Because they have different products they're looking at. So, for example, Consumer Reports is looking at some CMS data. I don't even know. Health grades with some safety stuff. Leapfrog looks at a different set of criteria. There's only 10% of the list. So the thought that individuals, like consumers, could actually look at this kind of stuff and go, oh, they're awesome. Ooh, they're terrible. What are they going to do? How do we give people this? So let's finish off with data. So harnessing data. One of the fascinating thing to see is that I was on a panel with the CEO of 23andMe. Like, how many of you have had your genome checked? Okay. Anybody else? And so I was on a panel with the CEO of 23andMe. And they're very, I love genomics. A lot of people don't get me wrong about genomics. But I was quoting the Wall Street Journal 2 weeks ago saying, like, I bet I could more accurately predict your risk of a heart attack based upon your visa than your genome. And if you think about it, it's probably pretty true. Yeah. So that you look at my genome, but like I got a Wendy's frequent flyer card, I'm doing all this other stuff. It's pretty obvious that I got a problem. There's a lot of that kind of data. What we're learning is that the information that we have is not the information that healthcare has. It's not the information that we need. Very concrete example. So you have 3 diabetics who are discharged from a hospital. The one that's most likely to get readmitted, look at what's the most telling thing. It's not their hemoglobin A1C, it's not their BMI, it's not the number of minutes they're on, it's none of those things. It's their credit score. Someone with bad credit is most likely to get readmitted to the hospital. And if you think about it, it makes sense. If you've got bad credit, you might be skimping on your meds, you might be actually have your car might break down because it's not very reliable, you might not make it to your appointments. It's actually pretty telling. And we've looked at a number of things like that. One of the most interesting things is we look at shopping habits related to certain lifestyle issues. If you shop at Home Depot and you stop shopping at Home Depot or you slow down some changes, your risk of depression is just gone. You think about you stop kind of caring, you stop doing something. We've done some work with the VA on suicide. Suicide's really tricky. Depression is very common, suicide is relatively rare, but obviously if you commit suicide, it's totally game over. So it's something you really need to prevent. And we looked at cell phone, because people voluntarily go down this program, right? First thing you notice is people get more depressed. The geodynamics of what they do gets smaller, right? You stop going to the mall, you stop going out to eat, you only go to work, and then maybe you stop going to work, they get smaller and smaller. So you can imagine the map of what you do over the course of your day. It gets smaller and smaller. What's more telling, it actually is more telling for suicide, is in the context of that shrinking, we see this change in how people interact with other people. The ratio of how much you talk versus how much you text changes. What you do is you talk less and you text more as a way of actually having less direct interaction. You see this constellation of stuff on your cell phone, right? That's a marker for highly increased risk of suicide. You can do an intervention. And so it's that kind of data, it's new kind of data. It's really interesting for us to do lots of very interesting things and allow us to provide better care. And all this I'm talking about is not just involving healthcare providers, right? So we see life sciences companies, pharma payers, everybody is trying to figure out how do they become part of this value chain? How do they actually contribute the right kind of data? Now, a problem we have there is that there's for data sharing, it's a problem of trust. So people trust the doctor, people trust like the American Diabetes Association. People hate the government, but they actually like NIH and FDA. Google, kind of midway down, people don't really trust Google, but they use it. What they do is they take that information to someone who actually can help. What do you think is at the bottom of the barrel of trust in healthcare? So payers, right? They don't care about you. Who else doesn't care about you? Drug companies? You're awesome. You got 2 out of 3. This is totally awesome. Football in your head. Anybody else? Unless you got it. Who doesn't care about you at all?
Insurance?
You already got insurers and pharma. Who just wants you to work harder? Your employer, right? So insurers, pharma, and employer, right? People least trust them. And the unfortunate thing is that these are the three groups that are providing most people with the majority of their health information. The other ones are saying stuff. Like your employer tells you to lift with your legs, right? The insurance company tells you, like, get your flu shot. The pharma says, like, sit in the bathtub with somebody, whatever it is. Those are the messages. And so as we think about how, and now you're having retailers getting healthcare, we've got telecom getting healthcare, we've got big technology companies like Salesforce and Microsoft sort of re-push themselves back in here. And we'll also have to figure out what's going to shake out. So it's a really dynamic time. It's a really exciting time in healthcare. Lots of innovation going on, lots of good new alignment systems that will allow us to do things. So it's an exciting time. So for all of you who are actually getting involved in the business, it's a really dynamic time to do. So a lot of change. At the same time, we're in an opportunity to actually improve outcomes, improve quality, improve service, lower cost, all this. I will stop there and take questions at the end of the day.
Yeah, so thank you so much. This is fabulous. You got me all fired up.
There we go.
I just wanted to ask you a question kind of under the delivery system reform umbrella, particularly around acute emergency care.
Mhm.
If you could maybe share some advice or what you think around galvanizing consumers to be, more to be better stewards of their acute emergency care, to kind of do it on the onset versus, when you actually need it.
So great question about like what it sort of boils down to is what do people do as their first decision? Because what we find actually is the first choice you make ultimately determines your outcome and cost. So if you have neck pain, right, you can go see an orthopedic surgeon, you can see a neurologist, you can see a neurosurgeon, you can see a chiropractor, you can go see your primary care doctor, you can go see a massage therapist, whatever it is you're going to do. Right? That first decision will ultimately determine your outcome. And right now, that battle is being waged around convenience. So that's why you see the Minute Clinic, so that's why you see Walmart that was getting to healthcare. That's why you see the launch of lots of telemedicine services. And that's going to be a short-term play. Because as big providers and payers are going at risk for your health, they want to do two things. They want to keep you in the system. They want to prevent linkage, that's what it's called. They want to prevent linkage. And so that's why you're going to start seeing places start doing all the stuff that retailers, reaching out, be able to FaceTime your doctor and all that kind of stuff. So they're going to try to keep you in that area. The other thing is that as people get on higher deductible plans, you have more out-of-pocket stuff, you're going to start realizing, depending on what's going on with me, I got to make sure that I'm actually spending money properly. So we pushed it in there. The weird thing is that a lot of the convenience factors, and how many of you actually been to a retail? Some of you. How many have been? They only have about 19 things because it's a very narrow scope of service. And people who are not that sick, not that complicated, are not the problem with healthcare. I'm sure someone earlier talked about 5% of people in healthcare, driving up 50% of the cost, whatever number it is. That's a small number versus the big number. That's our problem. And then you have sort of the big fat middle of healthcare, people who are kind of sick. They've got diabetes, got hypertension, whatever. And so what we're seeing is again this convergence around whether it's retailers or other things. How do we become part of that care continuum as opposed to how do we just provide some simple access? So that's why you see CVS, they're implementing Epic. Right? It's a way of actually sharing information. They want to be part of that. Walgreens wants to start doing oncology infusion. You see Walmart, as an example, Walmart charges $40 for a primary care visit. They charge $4 for their employees. It's so cheap they can't even bill insurance. It's more expensive to bill than to do that. Because they found that their customers are underserved, but their employees are also underserved with all sorts of complex medical. So they want to bring that in and sort of pull those together. But I think what we're going to see is big rise in urgent care, even the rise in freestanding emergency centers, which have not been built for access. They're usually in very wealthy suburbs. Consumers who are just freely spending their money, very quickly you'll see big systems come in and say, we need to keep those people. Rather than fight the Walmarts and CVS's, we're going to build an alliance with care for the other questions, you're not there.
So, all the analytics and big data, nice. Oh, thank you very much. It's great. All the analytics and data collection and predictives that you're talking about are obviously very exciting. Is there a clause that one should be added around the cost of insurance and or payers' availability of having that information and impacting your availability of care? So, would they be using that information as a payer system to actually decide what kind of coverage you will have and how much they're going to cover, and how can we protect them ourselves, or is that a concern from your perspective?
Well, so the issue is you can actually now, again, we've done studies where you can do, you look like not the youngest, but not the oldest guy I've ever seen, right? And I assume you've had a life insurance visit someone's come to your house and they've done an EKG and they've drawn blood and all that stuff. We've actually shown that you can, rather than do that, just go through your all the publicly available, purchasable marketing data, and it's much more accurate to figure out your risk of heart disease, of diabetes, of sudden death based upon your frequent scuba diver and bungee jumping car. Those are easy to figure out.
Is that reassuring?
So it's creepy. It's a huge creepiness factor.
Right.
And
Same point.
one of the ways that the insurers are doing it, people in the exchanges, is that the exchanges, people going out to the individual market, they don't know anybody. But so you think what insurance companies want to do was skip Baltimore City and go out to parts of Howard County or other places like that where people are probably very healthy. And the nice thing is in a value-based world, you can use that data to predict who is not healthy. Because healthy people suck, right? In terms of the payers and providers because they have unpredictable healthcare needs. Versus people who are kind of sick but haven't been taken very good care of, you can actually improve their quality, right? So there's something you can elevate there. You can test it for diabetes, you can do a bunch of other things, and make some progress. And so when you're using that data to identify those. Another Wall Street Journal article was about employers using information. Right? So again, looking at their employees, figuring out, who's got this, who's got that. And my response to that is that it's relatively easy to walk the halls of an organization and say, hey Bob, you're pretty fat. Right? You don't need analytics to tell you that. What's much harder is the behavior change. And so what I think we're going to use the analytics for is to figure out how do we actually motivate Bob to change what he's doing, what's going to be valuable. And that's going to be it. The discriminatory part is very scary.
But that's the point. That's
Yeah.
the question. That doesn't bother you. That
Yeah.
scary little thought doesn't bother you. Just ignore that.
Well, I mean, you're working on an Apple device right now. Like, if you think for a moment, the number of people who are monitoring your activity, right?
You're not helping me. I mean, I understand. It's still the same point.
Yeah. So you're going to get something. Right? So the issue is that you're probably going to be okay with that happening as long as you get something. You get a discount, you get someone providing you better care, you provide a more personalized kind of service, and they're offering the right kind of stuff. You'll be okay with that. You will not be okay with that when they start discriminating against you. There are a lot of laws that have been around for a long time to deal with that kind of stuff. The problem is, of course, the technology moves a lot faster than kind of laws.
Yeah, there's no firewall.
Yeah, it's going to be a big challenge. But it's not just healthcare, right? So it's the other, there are so many other things. If my employer found out that, I renewed my motorcycle insurance, they go, Carey, you're riding your bike? No, that's bad. Right? That there's so many things that you can get from this data, that's not even protected. Your health information is it's generally well protected. All the other stuff you do, where you shop, where you go, what you've done in the process, that's the stuff you should be scared of, and that's what we sort of Internet of Things. Here we go.
Question here about consumers.
So your question really around risk adjustment, which New York State did, was just to say, look, these results are bad, but they're actually better than you expect. The weird thing is, Massachusetts actually did public reporting stuff, and only Tufts University came out well ahead of Brigham and Mass General in terms of quality. So I think what we need to get, I think of the Phillips grad house in Denver, right? So you can, I could go to Phillips, right, and get some seafood, or I can go to Red Lobster. I can look at, Zaggett's guy or the Baltimore Max, whatever it is, and I can look and say, I can understand what's the quality going to be, what's the cost going to be, what's the ambiance. And healthcare is going to move in that same direction. We're going to have social media information about the service, so you know what it's like to live there. We're going to have publicly available quality, so you know how well people do when they get there. And we'll also have the cost data. What is it cost? So anyway, with that, I think we're out of time. So I don't know, my name is somewhere, but I'm one of the few Harry Greenspuns in healthcare. You can look me up, find me on LinkedIn, whatever it is. We have a lot of resources from our center. We're a research center, so we publish a lot of stuff, do a lot of webinars. So anyway, with that, thank you very much, and enjoy your